Welcome to the Healthy Gut Podcast, the place where you can learn how to achieve a happy, healthy gut with your host, Rebecca Coombs. On today's episode of the Healthy Gut Podcast, episode 7, I'm joined by Dr. Leonard Weinstock. Dr. Weinstock is board certified in gastroenterology and internal medicine. He is president of Specialists in Gastroenterology and the Advanced Endoscopy Centre. He teaches at Barnes Jewish Hospital and is an associate professor of clinical medicine and surgery at Washington University School of Medicine. Dr. Weinstock is an active lecturer and has published more than 70 articles, abstracts, editorials and book chapters. He is an investigator at the Sundance Research Centre and has participated in over 30 research studies. He's currently researching the role and treatment of small intestinal bacterial overgrowth in Restless Leg Syndrome, Irritable Bowel Syndrome and Rosacea. And he joins me on the show today to talk about Restless Leg Syndrome and Rosacea, particularly in correlation to SIBO. I myself suffered from Restless Leg Syndrome for years and didn't realise it was all to do with my gut. So I hope you enjoy today's show, episode 7, with Dr. Leonard Weinstock. Dr. Leonard Weinstock, welcome to the Healthy Gut Podcast.
Thank you so much, Becca.
It's great to have you here. I first met you at the SIBO Symposium this June in Portland, Oregon, which was wonderful to hear you speak at the symposium. And I was really lucky to be able to spend a few minutes chatting to you and also gift you one of my cookbooks, which was great.
And I enjoyed that.
Yeah.
It's a beautiful cookbook.
Thank you. I'd love to start with your story. How did you end up with an interest in gastroenterology, and why you're interested in SIBO in particular?
Well, my flight towards gastroenterology started with a strong background in internal medicine. I felt that internal medicine just gave somebody a viewpoint of the person as a whole like no other, whereas surgery was very limited and pediatrics was their own little thing and GYN was their own thing. But internal medicine just covered so much, and it often brought into these interesting differential diagnoses of patients who have been suffering with conditions for a long time. And that's what I found with GI, that there were many people who had unusual disorders, and so many of the gastrointestinal disorders were called syndromes. And that just really intrigued me, because I thought when I went to med school, everything is a textbook and it's all going to be spelled out. Well, when it comes down to things, so many things in gastroenterology are syndromes, and they're real mysteries. So I like to think of myself as trying to solve mysteries, because I've enjoyed detective shows and so forth. And that was one thing. And then the other aspect is, you do things, you do surgical techniques as well. So if there's a gastrointestinal bleeding, you're not just ordering the test, you're actually doing the test. So for me, that is a combination of the both thinking skills of medicine and the surgical techniques that makes it all happen.
And I think that anyone that has suffered from gastrointestinal issues can appreciate the detective mode, in that often one has to play real detective with uncovering what is going on with them.
It's so true.
Yeah. And talk to me a little bit about why you then also got interested in SIBO.
Well, SIBO was fascinating, because for years I've been talking to patients about irritable bowel syndrome, and so fascinating to me that there could possibly be a condition that 15% of the population has, but we don't really know exactly what's causing it. So for the first half of my career, from 1985 to 2000, it was just a matter of waving my hands and saying, we think it's a reaction to food, and your gut is hypersensitive and the nerves therefore are abnormal, and there could be stress. And all this kind of hand holding and hand waving, if you will. And then during that latter part of those 15 years, I became interested really in motility and irritable bowel syndrome, and was asked to be on a support group, on an internet support group for irritable bowel syndrome. And so I was the pharmacology expert and would give input on that, and on new treatments and so forth. And somebody asked me, well, what about the article that came out in 2000 for bacterial overgrowth and the treatment with neomycin and getting better from irritable bowel syndrome? And I actually had the American Journal of Gastro on my desk, ready to read, and I hadn't gotten to it, so I immediately turned to the article. I said, now that is interesting, that you could actually get rid of irritable bowel syndrome with an antibiotic. Mm-hmm. And by doing so, it was a real remarkable thought. And so I started treating empirically patients with the antibiotic and seeing some good responses. And then there's some written information around that time about doing a breath test. And I didn't have access to one but in my office, but there was a little hospital that had been doing breath tests for quite some time. So I started ordering them. And that put some science to what I was doing. And so I started treating with neomycin and then later ciprofloxacin and metronidazole. And some patients would get a dramatic response. Nothing else had worked before. They'd get a dramatic response. They'd relapse. I'd retreat them. And then they'd wean off their response and would not have the marked improvement that they once did before. And so my interest waned a little bit, but then it was peaked dramatically when Cefaxin or rifaximin was introduced into our country. And then I went to a educational meeting about that and learned about how this drug was not absorbed from the GI tract, and it was working mainly on the gut bacteria and the small intestine because of its properties, being able to work through bile, where the small intestine had bile on the surface, and you could get through this bile layer with the antibiotic, and it treated many different kinds of bacteria. And that the cool thing about it is that it didn't have a resistance factor like other antibiotics. It operated in a different way. So that was exciting. And then at the meeting, it was also discussed that it had a role in another condition called fibromyalgia, which I think many of your listeners know about or have, and that the breath test abnormalities were even greater in the patients with fibromyalgia. And so at that time, I was taking care of a relative who had post-infectious irritable bowel syndrome and restless leg syndrome. And this whole concept of post-infectious irritable bowel syndrome came out, which we'll talk about later. And I asked my cousin whether he had acquired the restless leg syndrome after the irritable bowel started, and he did. And then I started reading about fibromyalgia, and 20% of fibro patients have restless leg syndrome, which is much more than the general population. So I started thinking, well, was there a relationship here? Could, if fibro patients had small intestinal bacterial overgrowth or SIBO, could the patients with restless leg syndrome have the same? And so I treated him, and he had a dramatic improvement in the restless leg syndrome using the Cefaxin. And that started my interest in looking at things outside the gut, and basically getting back to internal medicine, where I had interest in looking at how the body is affected and where does this stimuli come from. And so that's how I got started.
So I'm interested to know, I think it's fascinating that your journey and interest and what's really interesting is that it's looking at the whole body and realizing that there are connections between one condition and potentially another. I'd love to know what you commonly see in your practice and who are the types of people that you're regularly treating?
Well, on the office side of things, a gastroenterologist will often treat irritable bowel syndrome and acid reflux disease and Crohn's disease and ulcerative colitis. Those are the top four. Causes for unknown, causes for pain and bloating, that brings things up as well. And nausea is a big category of illness. And in the morning, most gastroenterologists are doing procedures and doing colonoscopy and looking for polyps and causes for diarrhea. So these are some of the things that a gastro does. With respect to who comes in with irritable bowel and what they are like, I see more and more of second and third opinions because they're often dismissed. And this is one of the things about syndromes and patients that bother me in our society and in the doctor's approaches, is that many patients, come in, their condition isn't easily understood. It's not like hypertension, where you can try one drug or another, and you can do one test or another to say which kind of hypertension they have. Up until recently, with both breath testing and a special blood test, we haven't been able to dissect the patients out from this big pie of irritable bowel syndrome into different specific pieces. So, for instance, if I can take a syndrome like irritable bowel syndrome and view it like a pie and slice out a portion who have it due to SIBO, then I feel, okay, I can treat these people very specifically. If it's gluten sensitivity, take out a portion, put it aside, and work on that with diet, and so forth, until you get to this idiopathic or conditions of unknown, where the same set of symptoms are dealt with by all these people in the syndrome. But if we can get out of our global view of irritable bowel syndrome as one unknown and stop treating them as if there's nothing specifically wrong with them, then we can start getting ahead in how we treat our patients.
And I just think that's music to my ears. I was one of those patients for years going backwards and forwards to doctors complaining of digestive complaints and being diagnosed with, that broad sweeping term, you have IBS and there's nothing we can do about it. Just deal with it. Stop being stressed and be careful with what you eat. So, it's something I lament on as well, that people, unfortunately, still today are being given a sweeping diagnosis with not much assistance on what they can do about it. I'm really interested to know if there are any figures around, this piece of pie, whether there are stats on, how many people with IBS are due to SIBO and how many are due to gluten sensitivity or other conditions. Is there any research around that we can kind of classify that piece of pie?
Yes. So if you look at the data for this new antibody test, because work has been done recently showing that there's an antibody in quite a number of patients with irritable bowel syndrome and diarrhea, that it is looking like up to 60% of patients with IBS-D, irritable bowel syndrome with diarrhea, have an antibody. And this goes back to this whole idea that some of our patients, and perhaps many of them, have post-infectious irritable bowel syndrome. So just to put that concept into facts, it's a 7 to 30% chance that when you get an infection with a bad bacteria, that you'll get post-infectious irritable bowel syndrome. You never had IBS before, but then sometime after, usually 3 months or more, you'll get irritable bowel syndrome. And so with this antibody testing, antivinculin and anti-CBT4, there's evidence that these antibodies destroy the myenteric plexus nerves, the nerves that are running alongside and into involving the small intestine. And if you lose those nerves, then you're losing the contractions at night that keep our small bowel clean. So if we damage the cells, interstitial cells of Cajal with this antibody, you lose the migrating motor complex, the sweeper wave that keeps the small bowel free of bacteria, and then you're at risk for getting bacterial overgrowth. So studies have been done suggesting by statistics and projection that up to 60% of patients have IBS due to this autoimmune condition. Which is interesting because if you look back at breath test results, between 40 and 60% of breath tests were positive in patients with IBS-D. And so that is sort of a one-to-one correlation there that now makes sense. We just had to deal, however, with the problems of the breath test, that it's not very specific, and there's a lot of non-believers in the medical profession, in the research community, because of certain aspects to how sensitive it is, that it just seems to be too non-specific. But with a blood test, looking at an antibody, that gets to hard data that can be really looked at very clearly.
Definitely. And it's such a shame that here in Australia, we don't have access to that test yet. So hopefully one day soon we are able to do that test here as well. But it is available in America. And I don't know if it's available anywhere else in the world. Do you know if it's available in any other countries?
Not to my knowledge.
In terms of other pieces of that IBS pie, who else makes that pie up? What other conditions can cause that?
Yeah, so certainly food sensitivities, whether they be specific or non-specific. Certainly there are some celiac disease patients that can be labeled incorrectly as irritable bowel syndrome because the symptoms are so similar many times. But hopefully we've taken them out of that idiopathic pie. Gluten sensitivity, I think, fits in it because in general, we don't have any biopsy proof that gluten sensitivity clearly exists. Now, there's some, I've seen some electron microscopy where people have gluten sensitivity, they don't have celiac disease, and yet if you look under this extremely high-powered microscope where you're really only looking at a couple of cells at a time, it's so high-powered, you can see these little vacuoles or little balloons near the lining, suggesting that gluten sensitivity is a real disease. But at this point, I would say 2% of the population has gluten sensitivity. And there can be other symptoms that go along with it, including headaches and fatigue as well. Other aspects. Well, I think that the nerves are abnormal in many patients who have irritable bowel syndrome. We do see mast cells MAST cells that are deposited in the lining of patients with irritable bowel syndrome. And we see other inflammatory cells that come in to the lining. So I think there's an inflammatory type irritable bowel syndrome, which is where I think some of my patients who have failed many things get better with low-dose naltrexone because it reduces inflammation, in particular lymphocytes. So mast cells, I don't think have received the attention they deserve. And there are some nice studies showing that the closer the mast cells to the nerves, the more pain a patient would have with irritable bowel syndrome. And mast cells release a variety of chemicals like histamine and tyrosine, which activate the pain sensory fibers. So that may be some of the reasons why we have specific food sensitivities, especially in irritable bowel syndrome. Food, obviously, in your book is well demonstrated, plays a big role in SIBO in terms of what we're feeding our bacteria. Okay? So if you feed your bacteria that you've got in excess too much carbohydrates and undigestible sugars, they're going to have a feast and cause bloating and gas.
They are, and uncomfortable symptoms as well.
Right. Now, finally, I think there are patients where they have these abnormal nerves. Now, are they inflamed or just abnormal for some other reason? Perhaps some tract in the brain gut tract is off kilter, but we have this visceral hypersensitivity at the heart of many patients with irritable bowel syndrome, such that you stretch the colon, you stretch the small intestine, and then you're going to cause problems with pain. Again, that could be going on at the same time bacterial overgrowth is going on. So you increase your gas production, you stretch out the small intestine before the gas is able to travel to the colon to be expelled, and it takes longer to get absorption of the gas in the small intestine, so it stretches out, and those nerves get activated and cause problems.
So it's really a bit like a vicious cycle in that if the gas continues, the nerve damage can continue, which can lead to more motility issues, which kind of keeps going around in circles by the sounds of things.
Yes, yes. And then, of course, we step towards, well, what else do bacteria do? And they cling on to the small intestine lining. The small bowel doesn't like, it's not used to having bacteria there. So it really is not used to have these toxic bacteria clinging on. And then a lot of these cells, bacterial cells, cause damage to the lining of the intestine and increase intestinal permeability, so-called leaky gut. And when that happens, then other chemicals, food antigens, or bacterial byproducts get in there, and that stimulates the lymphocytes to ultimately produce inflammatory proteins called cytokines, and draw in other inflammatory cells causing inflammation. And then that damages the lining of the intestine, which then has a vicious cycle of its own, becomes leakier, more gut toxicity comes in, and more inflammation starts. And this is where I think the gut starts reaching out to other parts of the body. And it may be a lot of what you're going to get is what your biological makeup is. So if you've got a certain genetic makeup or phenotype, you're more likely to get one disorder versus another.
And
I've seen, one of my first patients who came in, had all the symptoms, it was one after another, post-infectious irritable bowel syndrome, then restless leg syndrome, then fibromyalgia, then interstitial cystitis. And it's just one after another. Every 2 years, she got a new syndrome. And she actually we were able to reverse virtually all of her problems with antibiotic therapy, and then ultimately with naltrexone settling down the inflammation.
Wow, that's fascinating. And so what is your approach when it comes to when a patient presents for the first time in clinic and they're in a bad way? What do you commonly see from someone that is complaining of irritable bowel syndrome, and then how do you approach their treatment?
So IBS is generally defined as abdominal discomfort 3 months or more per year, with associated changes in the bowel frequency and form, and with partial relief of symptoms with elimination. And I say that partially because that doesn't really account for all of the patients with small bowel symptomatology, because those patients are having issues with distension and bloating, and ultimately, if there's enough acidity that is created by the bacteria, it may cause contractions and increase output of fluid, and then they get diarrhea. Or, as we've gotten to know over the last 10 years, that if they're making bacteria making methane, they not only get bloating, but they get constipation. So my history taking is really important in terms of defining their syndrome, seeing how bad their bloating is, seeing if it's visible bloating as opposed to just feeling distended, because if they're not visibly bloated, that somewhat decreases the likelihood of SIBO, but not entirely. And on the vice versa aspect of that, abdominal bloating can occur without SIBO, just because it's a relaxation of the lower abdominal muscles in response to pain. And so you relax the muscles, that helps alleviate some of the discomfort in general. So there's a couple of different mechanisms for bloating. Asking about the type of gas that they have, how malodorous is it, are they having any passage of the gas chemicals into their mouth with bad breath, or chemicals that are actually coming out into the urine. Those are important questions too. Then the workup I do is perhaps not, what everybody does. I would say we actually do quite a bit of breath testing to get a feel of how severe the abnormality is. If we've got a very high peak on the hydrogen, those patients can be tough to treat. We know that they may need several courses of therapy or drawn-out courses of therapy. Motility may be a big issue, and that's where getting the blood test could be helpful. That IBS check, the antivinculin, could be helpful. Although I find that actually to be even more helpful when I've had patients who have been relapsers, frequent relapsers for what I think should have worked, to say, okay, maybe it's not this post-infectious autoimmune disease. If it's not, what is it? So do they have some other disease that is associated with small intestinal bacterial overgrowth, such as scleroderma or pseudo-obstruction or adhesive disease?
I'm quite interested in the comment you made about that bloating doesn't necessarily mean it's SIBO, and something that I hear from people quite frequently is that they've treated their SIBO, they've received a negative breath test, but they're still bloating, and they're feeling particularly uncomfortable and embarrassed about that, because no one wants to look pregnant when they're not, man or woman. So what would be your advice to somebody that's listening to this podcast that is still bloating, even though they have successfully, at this point in time, treated SIBO?
Well, there are other causes for it. Okay, so that's something that you need to be to think about: air swallowing, gastric outlet obstruction, small bowel adhesions, diseases like pseudo-obstruction, although that is often associated with bacterial overgrowth. Air swallowing can be a tough one. I mean, there are people who have nervous habits of taking gulps, drinking out of the bottle water, and gulping down water with it. So that air, which is typical atmospheric air, does not get absorbed very well by the small intestine. So that's an aspect. And then finally, irritable bowel syndrome without bacterial overgrowth can be associated with pain. And again, it could be just relaxation of the gut wall to deal with pain. It's kind of like undoing your belt buckle when you're uncomfortable. It makes a difference. It gives more room for the organs to move around.
Definitely. And I'm really interested in this sort of gulping air or drinking from a bottle. Is that just literally when you're drinking from a water bottle that you can be taking in air, or is there something that people are doing specifically when they're drinking that causes the air to go in?
Well, it's the glug, glug, glug. When you hear the glug, glug, glug sound, that means air is going in. And if it doesn't come out as a belch, then it's going to stay in your gut.
Ah, okay. Interesting. Wow, that's really interesting. And it's something, I at times have been known to, gulp down drinks, but my mum can't. She just takes sips, and we've always teased her about that. But now I think that's probably a good thing that she's just sipping her liquid.
So she's prim and proper and taking sips and not running around. Sure, that's good.
And also not potentially swallowing air, which is good for her. Are digestive disorders and discomfort on the rise, or is it that we're just getting more aware of them?
I think there are two main factors. Number one, a lot of people who are sitting at home just dealing with this on their own are becoming aware that there's more reasons to complain. They may have better access to health care, and so they're bringing attention to their doctors now. And there's a whole series of studies showing that there are many people who have yet undiagnosed, untreated irritable bowel syndrome. With respect to causality, and could there be an increased causation for irritable bowel syndrome, if we just take the case of post-infectious irritable bowel syndrome, there I think are a couple of things. Number one, people are traveling more, and they may go to underdeveloped countries or countries where cleanliness and safe water supplies are not at hand. And then on the flip side, if we're getting more fruits and vegetables from foreign countries, then it puts us at risk for getting infections because they're coming in and we're not washing our food as well as we should.
And I'm interested to know whether once you get some food poisoning or infection from a contaminated food, whether that makes you more susceptible to it. Because I've found personally that I've travelled quite extensively as an Australian. It's almost a rite of passage. We leave our country and we go off wandering. And so I've travelled through Asia, South America. I lived in the UK for 7 years, so I travelled throughout Europe. And I've been into Northern Africa. I went to Egypt. And it felt to me that every time I went away, from the first time I left Australia, I would get food poisoning. I would always end up with food poisoning, and I've picked up parasite infections as well. I've done that a couple of times, and it feels to me that I'm susceptible because nobody else that I'm traveling with seems to get sick like I do. So am I now more susceptible because of the infections I've received in the past?
Well, perhaps your gut is not yet healed completely. It's one possibility that if you don't have an intact bile layer protecting your small intestine, and or let's say the mix of bacteria in the colon have been altered by antibiotics or by bacteria shifting things, you may not have the protective balance in the colon that you once did, putting you at risk for other bacteria coming in. And so your immunity may be altered in the setting of SIBO, such that, you're at risk for other insults.
Definitely. And I know that I've done all of that travel I've talked about was prior to me discovering I had SIBO and then working on healing my gut. I haven't left Australia since. So it will be interesting to see what happens next time I travel after taking a lot of effort to heal the lining of my gut. Let's talk about restless leg syndrome. I know when I first heard about SIBO and I heard that restless leg syndrome was a common symptom, I felt like a hallelujah moment after years of having very annoying restless legs. I now had an answer for what had happened and I no longer suffer from it now that I've treated SIBO. Can you talk a little bit about why that occurs and what restless leg syndrome actually is?
Well, restless leg syndrome is defined as the compelling urge to move your legs while you're awake, in the evening, getting worse at bedtime, with usually a disagreeable sensation. So it could be a creepy crawly feeling, a tingling, an aching, and with that urge to move, you'll get temporary relief, or if you're walking, you get up and walk, you can get relief. So it makes it difficult for people to get to bed. Now, it may be associated with kicking and jerking in the evening while you're actually sleeping. That's periodic motor limb disorder, so it runs in parallel with it, but it doesn't necessarily mean that if you just kick your legs while you're sleeping, that means you have restless leg syndrome. Restless leg syndrome, again, is you're conscious. People could be on long trips in the car or plane, and they just have that itsy feeling. They got to get up and walk. They just can't keep their legs still. So it's very bothersome. And it is associated with two significant problems, hypertension and stroke. There's a higher risk. So whether that's through increased sympathetic nerve tone, we're not sure, but it's not just it's a bothersome problem. It actually interferes with getting to sleep, and people can wake up and then they have it and they can't get back to sleep. So it's a real problem. But what's fascinating to me is when you look at the condition, you've got primary or restless leg syndrome of unknown cause, you've got familial restless leg syndrome, and then you've got secondary restless leg syndrome. And there have been 50 conditions that have been reported to be associated with and or contribute to restless leg syndrome, and of which 40 have been looked at to have comparison to control groups. So there's really very specific disorders, 15 different neurological disorders, 5 different GI problems, 5 different rheumatological problems, 6 different metabolic problems, 5 pulmonary disorders that actually are associated with restless leg syndrome. And for years, people have thought, well, there's not enough iron in the brain. And there have been studies looking at that. because if the dopamine cells don't have enough iron, they don't function well. And so that gives rise to this feeling. And why it occurs at night, we're not 100% sure, although there is some thought that influx of iron occurs more at night in normal people, and if you have restless leg syndrome, that's not happening. But of these 40 conditions, 15 have been previously tested on their own for small intestinal bacterial overgrowth, and all 15 have had positive tests. So like people with irritable bowel syndrome, chronic liver disease, pulmonary problems, rheumatological conditions like rheumatoid arthritis have been associated with small intestinal bacterial overgrowth. So that really made me exciting to say, okay, well, maybe it's all about the gut. And the problem is when I started looking at drug studies just aimed at treating the gut only for SIBO, I get good response, but not everybody was responding, and there would be a limitation to how good people got. But when I started adding naltrexone to it, then I had better improvement. And what happened was I started looking at the literature, and it turns out one of my research partners in Vanderbilt had looked at the amount of endorphins in the brain in patients who had restless leg syndrome, and there was less endorphins in the brain, and the endorphins protected the dopamine cells in the setting of iron deficiency. So now what we're doing is we're treating SIBO and giving endorphins to increase, we're giving low-dose naltrexone to increase endorphins to help get into the brain and protect the brain cells and the dopamine functioning. So that's part of it. And then finally, inflammation and or immunological disorders with these 40 conditions is very common. And so we're looking at, is there abnormality of the T cells? And remember I said at least in the gut, we can have abnormal T cells, and conceivably antibodies can be formed by these T cells, and then perhaps those are attacking the endorphin cells in the brain and contributing towards this. So a lot could be going on with restless leg syndrome, but with what I have called sequential treatment, I've gotten very good results. We treat the SIBO first, and then we give the therapy with the LDN afterwards. And in terms of one study that I looked at with 40 patients, 65% had a markedly better and or moderately better response than they did before treatment. So, some of these patients who were markedly better went into complete remission, which just generally doesn't happen in treating restless leg syndrome with conventional therapy.
That's so interesting, and I'm kind of also living proof that once you start working on the gut, restless leg syndrome kind of vanishes. It was amazing. I used to get driven crazy at night with my feet feeling like they were just full of ants, and the worst place for me to get restless leg syndrome, which I always got, was on long haul flights, and I used to fly backwards and forwards between Australia and the UK every year, so 24 hours of travel, and by the end of it I felt like I was ready to rip my feet off. I was going crazy. Wow. And I found actually as well for me that my restless leg syndrome got worse when I was tired, which obviously you get very tired on long haul flights. So the sign for me that I was getting tired of a day or a night was my feet would get very uncomfortable. But it's fantastic. Fascinating, such fascinating stuff. The other condition is rosacea, and I'd love to hear a little bit more about what that condition is and its connection to the gut.
Well, rosacea has different forms. It generally involves the skin and the face, the cheeks, the chin, nose, and forehead. And it's reddening, flushing, bumps with papules or pustules, or thickening of the skin. But it can also involve the eyes. And the area of the eyes that are involved are the lids and the glands that produce the mucus and the tears, the Meibomian glands. And it should be considered a syndrome too. It's funny that they don't call it rosacea syndrome, but it is yet another condition that we don't really know in the majority up until 2008. So I was reading one of my journals in 2008, and lo and behold, there was a study out of Italy where they made a correlation of rosacea and SIBO, and they took 113 consecutive rosacea clinic patients and gave them breath tests, and 46% of those patients had a positive lactulose breath test. Now, I'd like to say one thing about breath testing, that we did a study of completely healthy patients, 30 completely healthy volunteers, and 10% had an abnormal breath test. So, and yet there was no reason to expect it, no symptoms and so forth. So it's not 100%, but even if you looked at 10% positivity of controls versus 46% of the rosacea patients, that's still very significant. And I looked at 63 consecutive patients that came to my clinic mainly for colonoscopy. I'd identify them and say, would you like to get a breath test and see if we could treat you a different way? And my percentage was about the same too. 41% had a breath test that was positive who had rosacea. So in the Italian study, they did look at age-matched controls, and they had 5% that had a positive breath test. In their study, if the patients had a positive breath test and they were treated with rifaximin or Xifaxan, basically for 10 days, they had a relatively smaller dose than we're currently using now. They used 1,200 milligrams a day rather than 1,650. They had a significant response. Approximately 70% cleared their rosacea completely, and 21% had a marked improvement. So close to 92% had a dramatic improvement if their breath test normalized. So that's pretty exciting. And at the same time, they compared them to placebo, and the placebo patients, 2 out of 20 worsened, and the rest, 18, were unchanged. So that's pretty powerful statistics. And their GI symptoms got better as well. So when they looked at patients who did not have a positive test for bacterial overgrowth, none of those patients got better. And so that's pretty good evidence that we have an effective treatment. And then I looked at my statistics, and basically 46% of my patients had a cleared or marked response, 25% had a moderate response, 11% mild, and 18% unchanged. And these are patients who had a positive breath test and were treated. And I'm getting similar results in patients who have ocular rosacea, and a number of the patients I see with ocular rosacea have the disease limited to their eyes, but only about 30% had a positive breath test in that setting. So dermal involvement is a bit more significant, and yet it can play a role in patients who have the ocular rosacea, where you get dry eyes and foreign body sensation and redness of the cornea as a secondary phenomenon.
How interesting. And do we understand why SIBO can lead to, or what the correlation is, I should say, between SIBO and rosacea?
Well, it hasn't been tested, but my feeling is it's related to systemic cytokines, namely these chemicals that are triggered by our leaky gut that then travel systemically. And if you've got a gene that makes you predisposed to having rosacea, then you're going to get your skin activated, inflamed, and affected.
And I hear from a lot of people that they often have skin complaints, as well as abdominal or gastrointestinal complaints as well. So they very much seem to go hand in hand.
Absolutely.
Yeah.
Absolutely.
One of the things that I used to be absolutely terrified of when I was quite unwell was that all of this was leading to cancer. And I know I'm not alone in that fear. I hear from people all the time saying, I'm so scared, I'm just waiting for a diagnosis of cancer. Are there studies to show that undiagnosed or untreated digestive disorders can then lead to digestive or gastrointestinal cancers, or is it us just being a little bit nervous and hypochondriacs?
Well, I think you have to look at two things. You've got two big organs in your body. You've got the small intestine, that's 15 feet, and you've got the colon, that's 6 feet of intestine. And in the colon, you've got anywhere between 13 and 100 trillion bacteria in the gut. And I think, there are some studies to suggest that colon cancer can have a different set of bacteria in the colon that predisposes towards colon cancer. So I think if anything is going to increase the risk for cancer, it will be an imbalance, or what we call dysbiosis, in the colon. And there are many medical conditions ranging from Parkinson's disease to diabetes, where an imbalance in the gut bacteria are playing a role, and mainly in the colon. So I think that SIBO per se, I've not seen research to really support risk of cancer in that setting.
Mm-hmm. And how do we find out? Is there a way for us to find out if we have an imbalance in gut bacteria?
So there are companies that do analyze the bacteria. You send a stool sample into a company like Genova, and then there's Rocky Mountain company. There's I think one other that you can send stool samples in to get a bacterial balance, to see what's out of whack, to see if you have a narrow group of bacteria that are there as opposed to a wide spectrum of healthy bacteria. Then the trick is, well, how do you treat that if you do have that? And at this point, there's some evidence that the FODMAP-free diet can swing yourself to a healthier state. I think the same could probably be said for a specific carbohydrate diet, although I haven't seen evidence of that, but I think it's possible. And probiotics may or may not play a significant role, just because we're talking about taking in billions of bacteria, and that's thrown in a mix of trillions, and the degree that those billions can make a big difference is questionable. I think that's not to say that you can't get benefit, symptomatic benefit, but can you turn your whole gut bacteria around is uncertain. So I think changing the food that your bacteria are eating in the colon are probably the best ways to get a healthier mix of bacteria.
What about fecal matter transplants? What do you think about that?
I was going to say that. Yeah. So, I mean, I think there's some patients who have totally refractory irritable bowel syndrome, and changes in the gut bacteria in the colon have been associated with irritable bowel, with diarrhea. That may be a very good future way to change it. My only concern is how effective will it be? Because, we do these colonoscopies, you clean out the colon perfectly, and then 2 days later you're having bowel movements, half of which are fecal byproducts. So it comes back very rapidly. So putting in healthy groups of bacteria, it may require treatment after treatment after treatment to really get a foothold of this new bacteria to overwhelm your unhealthy mix. But I think it's possible. I think that it's possible that manufacturers of spores, capsules with spores of bacteria, where you can get anaerobic bacteria into the colon, which is really important, could be helpful. When we're taking probiotics, are generally aerobic bacteria, so they're maybe not as likely to survive in the colon, which is an anaerobic setting.
And just going back to SIBO, I'd love to know whether, how often you see success cases with SIBO, and if you feel that SIBO can successfully be treated and kept away for good.
So, is it curable? Well, I think it's highly treatable, and some patients can be cured in time. And that is a question to be addressed with future studies. So if we had a wonderful treatment for, let's say, the autoimmune aspect to irritable bowel syndrome with this, antivinculin, then it's been shown that if you can get rid of the antivinculin by experimental means, the cells that are causing slow motility could get better. And that's where I'm hopeful that some of my patients who are being treated with naltrexone, where there may be lessening of the autoantibody, and perhaps with herbal therapies, could get better and their nerves could regenerate. In time, some people who have autoimmune diseases do get better. The stimulus to the production of them get better. So if we're aggressive in treating the bacteria, we're aggressive in treating the gut lining disturbance, it may lessen the production of those T cell activities and the antibodies they're producing. So what percent get better with standard 2-week course of antibiotic therapy? I say about 80%. And then the other 20%, you have to retreat, and then many of those get better. If they're due to motility disturbance, keeping it away by medications such as low-dose erythromycin, or sometimes low-dose naltrexone or prucalopride, can stimulate the small intestine and keep the bacteria out by keeping the motility going. But if a patient comes to me, they've had it for 10 years, I say, well, there is a concern that we're not going to get this into a cure, but we can control it. The diet, I think, plays a big role in getting somebody into remission faster and perhaps keeping them there, because let's say you've got a situation where 90% of the bacteria in the small intestine have been killed off, but you're feeding them food, SIBO friendly food, if you will, or bacterial friendly food, then at some point it's going to tip the scales and the symptoms are going to be active, because the number of bacteria in the gut have overwhelmed what a motility medicine can do.
And in terms of the nutrition component, and it's something that I think people get very, they can get quite upset about, because food is something that they can control. They're eating it every day. Do you advise that people do remove or reduce their carbohydrates when they're treating SIBO, if they're taking, say, rifaximin, or do you, have them on, what would be a standard American or Australian diet? What's your approach?
Oh, no. I do a low FODMAP diet, no artificial sugars, except stevia, but no alcohol sugars at all, and as low carb as they can deal with, especially during the first 4 weeks of therapy.
And how long do you have them stay on that diet?
Generally about 8 to 12 weeks, and then start reintroducing foods that they desire. But they always stay away from fructose, high fructose corn syrup, which is like gasoline to a fire.
And so readily available in our processed food.
Correct.
Yeah, unfortunately. One of the things that I realized as I started to get as I worked on my health, was that there was not just the SIBO that I needed to address. There was other areas in my life, and I saw it as my 5 key pillars to success when it came to my health. My first step was awareness. I had to start to get aware of what was happening to me. How important do you believe being aware is in a person's journey to health?
Well, I think they have to be aware they've got a condition, and that they're going to partner with their doctor in terms of getting better. So awareness that they're not at fault for this condition, I think, plays an important role.
And I really like what you say about partnering with their physician. It's so important to find people that you can work with, because it's not always a quick fix. In terms of nutrition, and we have talked about it a little bit, but I know for myself, when I first had to strip out a lot of foods, I felt pretty angry about that. What do you see with your patients? Are they happy to eliminate foods, or are they often a little bit angry like I was?
They didn't express the anger to me. They may do it at home, but they don't express the anger to me.
Yeah, sure.
They just kind of want to know a time zone. When am I going to be able to eat pizza? It comes down to simple things like that.
And do you feel that people can go back to what they would consider a normal diet of being able to eat a pizza or burgers or fries?
Many do.
Yeah.
I would say many do. But I would say I've got several patients who say, I just fell off the bandwagon. I had much more fruit and wine, and that triggered a flare. So I'll hear that from time to time. And that's where they're living well with the 90% clearance, but there's still 10% of the original bacterial load in their small intestine. They feed it, then they're in trouble. And that's where I think your book, is very helpful for people could, come up with good diets that are healthy for the long run.
Definitely. I know for myself that I allow myself little treats here and there, but on the whole, I feel so much better for eating clean, healthy food that I don't really want to go back to the way I ate before. And I'm really happy to make food from scratch and, to know where my food has come from and to really limit the amount of processed food that now is in my diet because I feel good for it. And if you'd said to me 2 years ago when I first started this journey into, getting well with my digestive health, if you'd said to me that I'd be really happy to drink alcohol very rarely and not eat much processed food, I would have laughed and said, sure. Right. Okay. In another parallel universe, maybe, but not this one. Another component that I worked on was movement. I'm one of those people, I'm lying on the couch or I'm running a triathlon, and when I was feeling very unwell, my movement suffered. I'd been feeling pretty flat and I just wasn't moving my body. Do you feel that there's benefit in people moving, and that could just be walking or doing yoga or it could be going and doing a CrossFit session? Do you see any correlation with your patients in whether they're being active and moving versus being sedentary?
Excellent question. Conceivably, indirectly. In other words, if exercise, which it does, increases colonic activity, then there's less bacteria sitting around in the cecum, where retroactive movement of the stool up into the ileocecal valve could put more bacteria there and at risk for ascension into the upper small intestine. So it's conceivable that that's the factor involved. I haven't actually discussed that with too many of my patients, but that's very good. Plus, exercise in general just makes people feel better.
It does. I know when and for me, my exercise these days is walking. So I've gone away from the really intense exercise, and I am a podcast addict. Not only do I do my own podcast, but I love listening to others, and it's my time out when it's just me, myself, my podcast, the fresh air, and I love it. I love getting out and walking now.
Fabulous.
Yeah, makes me feel great. The fourth component that I had to work on was my mindset, because I had identified as being a sick person for my entire life, because I always had been. And I didn't know how to think of myself as a well person. I also found that I was pretty negative about things. I've already said I was pretty angry about removing foods and feeling really like the world was unfair, that I couldn't eat burgers and fries and pizzas. So I had to change how I thought about things. Do you see that with any of your patients, in terms of those that start to look at the positives rather than focus on the negatives get well quicker?
Interesting. I haven't evaluated that. I certainly recognize seeing patients who get well and feel better psychologically. And then there's some evidence that SIBO, inflammation, directly affects the brain in terms of the cositropin releasing factor, which then results in depression and changes in serotonin in the brain. So I've seen people come in for follow-ups who have their GI symptoms are better. They feel lighter on their feet, so to speak, and their color is better, and they just have a much better mood. So is it direct or indirect? I'm not sure, but I think that it can play a big role in their own mood. So SIBO itself and the inflammation it's associated with can be associated with change in their adrenal, hypopituitary adrenal axis. So it's hypothalamic pituitary adrenal axis is all important about fatigue. And perhaps if we improve that, we get less inflammation, less of the bacterial shells coming into our bloodstream, that will help in terms of how they feel, as opposed to wishing for better health and getting better health.
Yeah, sure. And the final piece that I had to work on was my lifestyle. So I had been chronically stressed. I wasn't sleeping well. I was getting to bed really late. So, not getting enough hours sleep at night. And I needed to readdress some relationships in my life of people that perhaps weren't the best influence on me. And so I needed to do that to support my journey to health. Do you see any correlation between sleep or, stress levels or even perhaps toxic relationships that people might be experiencing and their ability to manage or work through a condition like SIBO?
Well, in general, with irritable bowel and the abdominal discomfort, the more stress, the worse the discomfort. So there's definitely a brain-gut relationship going from north to south. With respect to rest is important because during that time you're fasting, obviously, you're sleeping, and you're giving yourself a little more time for whatever migrating motor complex you have or can generate with medicine to wash the bacteria out.
Definitely. And I, since coming through my SIBO treatment, I now do intermittent fasting. So I fast 2 days a week where I just eat dinner, and I feel fantastic for it. It really makes me feel really great. So that's been an interesting self-experiment for me. Yeah.
Yeah. Interesting.
Yeah, it's really interesting. I feel I have so much more energy. I feel really positive. And it's, for me, I feel like on the days where I do eat 2 or 3 meals a day, that I don't have as much energy as I do on the days that I'm fasting. So it's been a fascinating personal experiment of one.
Well, yeah, you've enlightened me and on many aspects this evening.
Oh, that's great. Dr. Weinstock, it's been an absolute pleasure to have you on the show. Thanks so much for coming on. I have learned a lot, and I'm sure my listeners have as well. If anybody wants to connect with you, what's the best place how is the best place for them to do that?
Well, short questions, little questions. If let's say if they want to learn about my research, it's all on my email site, my website, gidoctor.net. That's gidoctor.net, doctor.net. And then inquiries, as long as they're kept simple, I can handle some. lw@gidoctor.net.
Wonderful. Well, it's been an absolute pleasure, and thank you so much for your time today.
Okay. Have a great day.
Thank you. I hope you enjoyed episode 7 of the Healthy Gut podcast with Dr. Leonard Weinstock. And if you're anything like me, you have just learnt an awful lot about restless leg syndrome and rosacea and why they're so connected to the gut. If you would like to access the show notes from today's show or get any of the links that we talked about, head to thehealthygut.co itsy.com/Leonard. And that's where you'll be able to see a full transcript of the show. You'll be able to get all of the links to Dr. Leonard Weinstock and also look at the show notes as well. So that is thehealthygut.co/Leonard. Now, I absolutely love hearing your feedback. It just makes me feel so happy to be able to connect with the listeners of the show. So do leave us a review and a rating in iTunes. And it also helps other people find the show. The more ratings and reviews we receive, the more likely it is that someone who is looking for help around their gut health is going to find the show. Now, if you'd like to connect with us, you can do so on all the major social media platforms such as Facebook, Instagram, Twitter, YouTube, Pinterest, and Google+. And we are The Healthy Gut on those platforms. Coming up on next week's show, we are joined by Angela Pfeiffer, who is SIBO guru. And Angela and I talk all about the importance of playing your own private investigator when it comes to understanding your own personal health concerns. So do join me for episode 8 with Angela Pfeiffer, which is coming up next week. You've been listening to the Healthy Gut podcast with Rebecca Coombs. To learn more about the Healthy Gut or the podcast, head to thehealthygut.co/podcast. If you would like to help support the continuation of this podcast, you can make a contribution at thehealthygut.co/podcast. With thanks to Belinda Coombs for the production, editing and original music score of this podcast. To hear more of Belinda's music, head to soundcloud.com/Belinda Coombs. The Healthy Gut podcast is a production of The Healthy Gut. Thanks for listening.